So by the end of today's presentation, our goals is that you all understand the anatomy of the thumb a little bit better and the role that the basal joint plays in our hand functioning. You should be able to identify the causes, the risk factors, and common symptoms of basal joint arthritis. Together, we're going to learn about the diagnostic process and different treatment options, both surgical and conservative, for basal joint arthritis. And we will talk about some preventative measures and lifestyle modifications you can implement to maintain your hand health.
So before jumping into what basal joint arthritis is, not really knowing kind of where people's understanding of arthritis is, I kind of wanted to take a step back and just basically talk about what arthritis is before jumping into the basal joint. So arthritis, if you break down the word, arthro means joint, itis is inflammation. Right? So the word itself just means inflammation of joint. And the common analogy I typically use with patients is, treads on a tire. So every joint, this is a knee joint. So just for simplicity, the thigh bone, over here, and the bone down below. Is if my mouse is working, there we go.
Entertaining.
And every joint is going to have a layer of cartilage here. That's the cap on both the bones, right? And that helps create a smooth surface for both bones to kind of rub against each other, so decreasing that friction. Now, there's a certain thickness to that cartilage, right? So when we're all born, we have a certain thickness to that. But as we go through life, that joint will slowly, or that cartilage will actually slowly thin out, kind of like I said, treads on a tire. So that when you get a new tire, right, you have a thickness to that tread. And the more you drive, that tread becomes thinner and thinner. And that's what we call arthritis. So there's two forms of arthritis, what we typically call osteoarthritis, which is the wear and tear form of arthritis. And then the rheumatoid or the inflammatory arthritis, which most people commonly call rheumatoid arthritis. But there's actually a number of different inflammatory arthritis, which I listed here, like ankylosing spondylitis, gout, lupus, so on and so forth. But the most common one that we typically deal with is osteoarthritis. And this kind of breaks down the differences between the two and what you see in the joint. So in the far left, you have a normal joint, which is nice thick cartilage. You have the joint capsule, nice, not inflamed. And in osteoarthritis, you get that thinning of the cartilage. So you get this sort of bone on bone articulation here, which creates inflammation that generates swelling and pain. In rheumatoid arthritis, or in the inflammatory arthropathies, our body creates factors that sort of attack our own tissues. So it attacks the cells that line the joint, that creates an irritated joint, very inflamed, very warm, very red looking. And it affects numerous joints throughout your body. And so while you may get some thinning of the cartilage, mainly the entire joint capsule gets really inflamed, and they get a lot of changes and deformities to their joints that you commonly see, at least you used to see back in the day. Now we have a lot of medications that help control that inflammation. So we'll focus mainly on osteoarthritis, right? So the wear and tear phenomenon, typically it's activity related. So first thing in the morning when you wake up, you not pretty much, but oftentimes you may not have that soreness. But as you start to go through the day, if you've been walking a lot or if you've been doing some sort of activity a lot, you may start to get some soreness in your joints. So it's an activity related pain typically with swelling. Stiffness typically ensues later in the progression of the arthritis because the joint is starting to become more arthritic and the capsule becomes tighter. But the common sort of audible symptoms you hear is that crackling and popping. So if you get up from a seated position, if you're walking up and down stairs, you feel your knees like crack. That's osteoarthritis. That's the wear and tear that we're talking about. Common joints affected are the weight-bearing joints, so like hip and knee, ankle, the joints in your feet. But even like your cervical spine and your lower back, so that's why a lot of people have low back pain, because that's to support our whole body in an erect position, right? So that's why those joints tend to wear down. But one of the joints that's often overlooked, but is very common in the hand and wrist field, is the basal joint. So you may be wondering, what the heck is the basal joint? So this is a picture of the hand, and then it has the skeleton overlaid in it. So at the base of your thumb, so it's not in the web space, but all the way down here that connects the thumb to the wrist is your basal joint. So these are your wrist bones here. We call it your carpal bones. And this is your thumb metacarpal. So throughout this presentation, I'll be constantly saying, thumb metacarpal, and that's this bone here, kind of down deep into the web space here. And then the other bone that's involved in that joint is the trapezium. So that joint there is what we call the basal joint. So zooming closer into that joint is a very stout joint. It's what we are how we generate power with pinch and grasp. So there's about 16 ligaments that support that joint that holds that thumb in that position to the hand, or connects the thumb to the hand to the wrist, I'd say. And anytime you go and pinch or grasp onto something, the force that gets magnified on that joint is anywhere from 12 to 20 fold. So you can imagine there's a lot of force when you go and hold on to things. And it's that force that over time starts to wear that joint out. And these ligaments that have been doing work for 20, 30, 40 odd years, over time, they start to become more lax or more stretchable. And so that analogy I use is with tires is over time, your alignment may go out, or the tire becomes imbalanced, and that tire starts to wear out quicker. Same thing, these ligaments start to wear down, and then the joint will start to wear out soon after. So that's kind of the progression that we see. The unique thing about this joint I wanted to show here is different than most other joints in the hand or even the body, is that it's a saddle joint. So I have a picture of a saddle here. So it's concave in one field and then convex in the other. And so that what allows you to do circumduction with your thumb, and allows you to really get over to your little finger and really hold on to things. So it's a unique joint, and it has a lot of force that's applied to it. So taking that the next step. So over time, as you start to do more and more, that joint, that cartilage starts to wear down, and you get essentially bone on bone. So this x-ray is showing the basal joint arthritis. So normally in most x-rays, you see this kind of nice clear area between two bones. That area is what we refer as cartilage, right? So the wider that space, the thicker the cartilage. But as things start to wear down, you start to lose that space. And normally, and I'll show the picture of this later, but normally there's a space right through here, but you can see this is pretty much what we call stage 3 arthritis, which I'll talk about here in a little bit. Now, clinically, when we see a patient in the office, they can be various presentations. So the picture on the right is very classic with early arthritis. People come in with pain around the base of their thumb. You'll see what we call this shoulder sign. So you see this kind of, normally it's just more of a straight line as opposed to sort of this bump here. But that's the basal joint, and that's where typically patients will come in complaining of pain. But as things progress, you can get this kind of deformity, which is pretty severe arthritis, where you get a bigger shoulder sign. So the thumb is now assuming a posture more into the palm because the arthritis is getting worse. And then the MCP joint, so the joint distal to it, starts to hyperextend because the patients lose the ability to hold on to things with their thumb in that position. And when we get to this stage later, it becomes more challenging to treat. So why me? Right. So obviously at the base level, genetics do play a role, right? So there is a 6-fold increase in terms of prevalence of arthritis at the basal joint in women compared to men. And the primary thought there is that women tend to have more ligamentous laxity, or their ligaments tend to be more flexible or stretchable, right? And that laxity then, as we're using our hands and really putting a lot of stress and strain through it, wears down that joint quicker. So you do see it more commonly in females. You see it more commonly as we all get older, primarily because we are just using our hands more and more through decades of life. Interestingly, it's more common in the non-dominant hand. Patients will come in, well, why is it my left hand, even though I'm right hand dominant? I'm not really sure. I mean, it's just something that we see more prevalent, is that's more common in the non-dominant hand, but I see it commonly in both. I did talk about age. Patients who have connective tissue disorders. So these are conditions that, like I talked about, the ligamentous laxity. People who are extra flexible, who can like bend their thumb to their forearm, who can touch the floor without bending their knees and their palms. Those patients will no doubt have an increased risk of developing arthritis in their thumbs. Trauma. So anytime anyone has a fracture involving any joint, but certainly in the thumb, that increases their risk for developing what we call post-traumatic arthritis. But it is the second most common arthritis in the hand. The most common is the DIP joints, which is the distal joints in the fingertips. So signs and symptoms, obviously pain. Most of the time, patients will talk about pain kind of in that first web space. It's just come in, they call it carpal tunnel, but oftentimes it's just pain into that first web space. And then what I'll tend to do is I'll tend to push on the base of their thumb right at their basal joint, and they'll typically jump right off the chair, right? And that's just kind of a telltale sign that that's where the arthritis is. they'll have trouble, like in that picture I showed you before, of grabbing onto things because the thumb rotates into the palm. It makes it very difficult for them to get their thumb out to hold onto a cup or something larger. A pencil's not too difficult, but certainly larger objects like cups and things make it difficult. And it's not uncommon. About 30% of patients who have arthritis of their basal joint also do have carpal tunnel. We think it's just due to the inflammation, right, which is pretty close to the carpal tunnel, that causes increased pressure on the nerve there. So that's a common finding. So we'll talk about treatment options. Now, in terms of arthritis, whether we're talking about the basal joint of your thumb, hip, knee, the treatment options are all the same. It's about reducing symptoms. There's no way to regenerate that cartilage. So it's anti-inflammatories, bracing, therapy, which we'll go into here shortly, injections, and then eventually surgery. So I'm going to have Elli chat first about kind of some of those early options first before we get into the more significant ones.
Perfect. So as Dr. Netto just touched on, if you did not know before, we now know that arthritis is a progressive condition. So in therapy, the aim of conservative treatment is we want to restore as much thumb function as we can prior to that surgery. So this includes trying to relieve pain as much as we can, trying to increase the stability of that thumb, trying to increase pain-free mobility, and increasing strength as much as we can. So I will elaborate on this a little bit more in the coming slides, but what we're going to look at is patient education in joint protection, activity modification, and assistive devices. We're going to look at some sprinting and bracing options, and we're going to talk a little bit about strengthening exercises, and then Dr. Netto is going to talk on injections and analgesics. Okay, so because it is a progressive condition, the best thing that you can do for your hands is try to modify the environment around you to reduce the stress that you're putting on your hands day to day. So there's a lot of different ways that we can do this, and I have a lot of equipment over here that I'm going to kind of pass around so you guys can see as we're going through. But the first one here is, when possible, trying to use larger handles. When we're using smaller handles for things, it puts a little bit more stress on that joint. You're more likely to kind of sublux that MP joint forward. So by using built-up handles, which this was one of the sheets in the back if you are curious about this. You can buy these on Amazon. You can cut them down and fit them to different various day-to-day objects. And then you can see how that creates a more desired position for the thumb. It supports that a little bit and creates less stress on the joint. So I'll pass that around for you guys to see. Do you guys need this? Okay. So another way to reduce stress on your joints is, when possible, try to use two hands. Instead of tightly gripping with one hand, you can disperse that weight onto two hands. Another way is trying to use levers when possible. So sometimes turning a doorknob can be painful because you are putting stress on that thumb. You're gripping tightly, where if you're using a lever, again, it allows you to disperse that weight a little bit more evenly, reduce the stress on that thumb. And then lastly, try to use larger joints when possible. We've all been there where we want to carry all of our groceries in at once and you end up loading up both your hands. But instead of trying to load up your hands, you could load up your shoulders, your forearm, taking that stress away from your hands. So I wanted to touch on also balancing rest and activity. Dr. Netto touched on this, where with osteoarthritis, when you're waking up early in the morning, that's sometimes when you have the least amount of pain. So you might be thinking, let me front load my day and do all of my hard work at the beginning of the day, get it out of the way while I'm feeling good. But sometimes that can lead to excess stress on your joints. And then you end up spending the next day or 2 weeks recovering from the stress that you put on your hands. So instead of front loading your day, it's better to break up those activities, find different manageable ways, listen to your body, kind of notice when you're starting to feel that pain in your joints. When you're doing activities, try to alternate the hands that you're using if it is possible. Sometimes that gets harder with more fine motor tasks, but if you're able to, use one hand for a little bit. If you can feel that getting tired, use the other one. When balancing rest and activity, it's also very important to use your rest breaks effectively. So when you're using your rest breaks, I'm sure some of you have found yourself there where you take a break and immediately what do? You grab your phone and you start texting or you start doing something, scrolling, and that's still using your thumbs, that's still straining your joints. So instead of just think you're taking a break, use that time effectively. Try to do some stretches, which if you go to see an occupational therapist or a hand therapist, they can give you a little bit more guidance on what those stretches and exercises could look like. But one of my favorite tools, which again, that's another one of the links back there, but is this little massage ball here. When we're using our hands repetitively, it starts to strain those muscles in your hand and they can start to get tired and tense. And one of the ways that you can work that out is by using a massage ball. So I'll kind of pass that around as well. And the way that you can use that is just on a hard surface, placing it on a hard surface, putting your hand over top and just massaging out those muscles. So there's that. And then lastly, there are so many resources out there and so many tools that have been developed to make day-to-day tasks easier. So like the example up here, there's electric can openers now. So if that's an activity that commonly hurts your thumb, it might be worthwhile to invest in something that is just pushing a button, because that day-to-day stress on your hand is only going to lead to more wear and tear and kind of push you towards that need for surgery. If you're able to modify tasks, reduce that strain day-to-day by using electric can openers, food processors, so many different tools, then you will be protecting your hands in the long run. Okay. So next we're going to talk about some splinting and bracing options. So there's a lot of different options out there, and I'm going to sound like a broken record, but if you do schedule an appointment with an occupational therapist or a hand specialist, they can definitely help you work through this and try to figure out what brace would be best for you, whether that's an over-the-counter brace or a custom molded brace. But when you do start looking into bracing and splinting options, there's things to take into consideration. So one of those things is, where is your thumb pain located? If it is just strictly at the base of that thumb, at that basal joint, then you may need something, you may benefit from something that is a little bit less cumbersome, only protecting that CMC joint. If you are starting to notice that you do have that Z deformity that Dr. Netto touched on, and you're having pain in that joint, your MP joint, distal to that basal joint, then you might want a little bit more protection that travels up the thumb. So such as like the Comfort Cool or other bracing options. Something else to consider is, when does your thumb have pain? Is it only during activity, or are you also having pain when you're resting? If it's just during activity, then you might want something that's a little bit more flexible, more workable, that gives you that support when you're doing day-to-day tasks. If you're also having pain when you're at rest, you might want something that's a little bit more stiff, providing a little bit more stability. And you can also mix and match braces. So I'm going to kind of pass some of these around so you can see them, but this first one that I'm passing around would be just kind of providing stability to that CMC joint, that basal joint. And then some other options here provide a little bit more support up the thumb. So you guys can just have that. And you can kind of see some of them have a little bit more workability, where some are a little bit more sturdy. And then kind of pass this around too. And then this last one here is an example of like a custom molded brace that a therapist could make for you. That's a little bit more sturdy, provide more stability. Last thing to consider is, what are your job and daily life demands? Because the role of conservative therapy is we want you to be able to engage in your day-to-day activities as much as possible. So if the brace is going to prevent you from doing those things, that's not our goal. We want to find one that's going to work with what you need to do every day. So if you have a job that requires a lot of fine motor control or a lot of dexterity, then you want something that's a little bit less cumbersome, that's going to allow you to still complete those roles. So now we're going to talk about thenar strengthening, which is strengthening those muscles in your thumb. So there are 9 muscles that provide dynamic stabilization of the basal joint. So they're all listed here. I'm not going to dive into the specificity of each individual muscle, but what I want you to gather from this slide is that there are a lot of moving parts in your thumb and a lot of muscles that are coming into play to work to protect that joint. And what you can do in therapy is work to identify where there's deficits, where there's weaknesses, where there's inefficiencies in that movement, and together work with your therapist to strengthen and improve some of those deficits. So next I'm going to show just a few common exercises. If you do go to an appointment with a therapist, we want to adapt your plan to fit your goals as best as we can. So everyone's plan is going to look completely different, but these are just some common things that you might see. So the first exercise up there is the CMC stability matrix that I do with a lot of my patients. And that is actually one of the sheets back there, if you did see that on the way in. But the role of these exercises is to implement pieces of isometric exercises, kind of neuro re-education. We're trying to retrain those muscles to create more efficient movement, and pain-free strengthening. And together, these exercises work to emphasize like a stable base of support to facilitate balanced muscle contraction. So you're holding this tennis ball in a stable position in that desired position of the thumb and isometrically strengthening in a pain-free range against that ball. So that there's more information on that sheet, but that first one is holding a tennis ball and you're just squeezing into it gently for about 5 seconds and then relaxing and completing about 10 to 15 reps of that exercise. The next one, very similar, but in this position, squeezing in again, creating that increased stability in that joint. And then the last one we are working on, it's called your first dorsal interossei muscle that provides a lot of stability to the basal joint. You wrap a rubber band around your fingers and you are just lifting that finger and then abducting it here until you see that muscle contract there. So if you have any questions about any of those, I can definitely show you more after the presentation. But then finally at the bottom here, these are just showing you some examples of different therapy putty exercises. And I know it seems a little silly to be playing with putty as an adult, but what the beauty is of this tool is that we can simulate so many day-to-day activities that you're struggling with specifically. So.
So we'll talk about some of the other options. Oftentimes patients, by the time they are seeing us, they've tried some of these things, right? So the over-the-counter analgesics, right? Bengay, Icy Hot, those work by some of the ingredients in there, like menthol and things of that nature, create an effervescent feeling to the skin, which then creates a cooling sensation that helps relieve some of the pain. It's really transient, like it's going to last for a few hours, but then you're constantly applying this and it kind of smells. But it does help. Like there's no question it helps, but you're constantly applying it. There was a topical anti-inflammatory called Voltaren gel. It used to be prescription strength. Now it's over the counter. Same kind of formulation of what you would take orally, but now it's in a formulation as a gel. Also very nice, but and it's useful in patients who maybe get some of the heartburn or reflux of taking ibuprofen orally. Now you can just apply it to the skin. It's not as strong as taking something orally, but certainly still beneficial because you can apply it just to the area that you need as opposed to all over. The next level up is oral NSAIDs, so anti-inflammatories like ibuprofen, Motrin, Aleve, whatever your favorite anti-inflammatory is, but some patients can't take that. There are other sort of prescription strength, either anti-inflammatory or what we call multimodal pain management. So using either low-dose steroids if you really need to go that high, but like Neurontin or gabapentin, which are used for nerve pain, can also be used to treat just general pain. Even some antidepressants like Cymbalta can be used to try and treat pain too. So there are other ways to try and, without having to go, because I don't really entertain narcotics at all, but there are other ways to try and address pain without going to that route. And then there are injections. So the kind of the main injections that's used throughout all arthritis is cortisone. I'm sure you all have heard of that. It's a very potent anti-inflammatory. It replaces the need of having taken something orally, or sorry, taking something daily. It's kind of a long-lasting anti-inflammatory. The idea is you give an injection and hopefully it lasts for 9 to 12 months. But over time, as the arthritis is getting worse, the injections have become less and less effective. And I tell patients, look, like we can kind of play this broken record as long as it's giving you relief for 6 to 9 months. But if it's anything shorter than that, where you're having to come in 2 or 3 months later, say my pain's back, then we need to talk about other options. In the knee, there is like Synvisc and these other what we call hyaluronic acid injections. You may have heard like rooster comb and things of that nature. Right? So they're just basically a lubricant that's of a factor that's commonly produced in our joints. It's FDA approved for the knee, but it's not indicated in the hand. They've done studies that actually have shown some pretty promising longevity to Synvisc and all these hyaluronic acid injections when compared to steroids. So hopefully, in the future we might have that as an option, but currently we don't. And then there's PRP and stem cells. Patients come in and asking about that. There's really no literature to support the use of PRP. It makes kind of conceptual sense where you're basically taking your own blood, spinning it down, taking the plasma, which has factors that are commonly recruited to the site of injury. But there's no data to support it, unfortunately. And so because of that, it becomes a cash pay item because insurances don't cover that. So, I tell patients, look, if you can afford it, I don't think there's any harm in trying it. It's your own it's your own blood, but you may not see the benefit from it. So it's one of those things, some people get some benefit, some don't.
We'll move on to surgery. I forgot, Ty is going to demonstrate also a kinesiotaping
Oh, yeah.
option to
Yeah.
provide stability to the CMC joint. So just
Yeah,
another
no worries.
bracing option, sorry.
Yeah.
So is there anybody right now, anybody having any thumb pain? Would you like to be our model?
Sure, I can do it.
Yeah. So if you want to come and sit up, or could we maybe sit up here so it can be in the camera?
Yeah.
Oh, right there is actually great.
It is? Awesome.
Under that table. Okay. So this piece just goes over the thumb, and straight down the wrist on the radial side. Stretch. And we're basically just gonna wrap the CMC joint in an X. So one going this way. Oh, sorry.
We can start over and go together.
So this gives just a little bit more support to that joint and hold it tight if you're doing activities where you still need to move your hand other than the splint. So you tell me how that feels.
Feels good.
How long can you keep that on?
2 to 3 days. If you get wet, you just got it right with a towel and.
Just kinesio tape. So it's, you know, the tape that they use to kind of help offload the
I'll be happy to
The
take
joint.
anybody who needs it afterwards.
for the next 2 to 3 days. So when you've tried taping, when you tried therapy, injections, anti-inflammatories, and you're kind of at wit's end, you know, the next option that we start talking about or considering is surgery. And this slide is meant to be busy. I'm not going to go into all of these little boxes here, but there are a lot of factors that kind of play into how we decide which surgical option to consider. One of the main factors that plays a role in is what stage of arthritis are we talking about, and we'll go into stages here in just a minute. Is there any instability in the joint? Because some people, like we talked about, who are very flexible, their joints can become unstable, or if they've had an injury, their joint can become unstable. So that is a factor into our decision making. How old the patient is, primarily that plays a role in their activity level commonly, right? So someone who's young, who has early arthritis, is going to be different than someone who's older and maybe just plays pickleball, right? So it's different things that play into how we decide what surgical option is best for them. So I mentioned stages of arthritis, and earlier I was talking about what you typically see, right? So on the far left, you see the trapezium. Where's my mouse? Here we go. Right, so this is the trapezium, and this is your thumb metacarpal, and you see this nice little good gap here. This is a good amount of space. We're starting to see a little bit of what we call beaking in the joint, but this is the earliest stage of arthritis. The next stage, you start to get bone spurs. So this is kind of a bone spur up here, another bone spur down here, even over there. And you also start to get narrowing of that space. That's because the cartilage is thinning out. Stage 3 and 4 is pretty obvious. There's really no joint space at all. The difference between stage 3 and 4 is now the arthritis is impacting the joint below. We call our STT joint. So when patients start to have now arthritis at both joints, that's kind of the terminal stage. That's when you start to see patients who get the hyperextension of the MCP joint and that Z-type deformity. So stage 1 and 2 is early stage arthritis. 3 and 4 is late stage arthritis. So when we talk about early stage arthritis, the goal is to try and preserve the joint. So one of the early procedures that was had come up, or someone had proposed, was actually what we call an extension osteotomy of the thumb. So the thumb metacarpal, what we do is we actually cut the metacarpal and then extend it and fix it with pins or plate, and have it basically realign the thumb. And the concept there is that you're trying to, kind of like what you do with your car when you get a new align or realign the wheels, right? So you're realigning the thumb to take pressure off of that CMC joint. And patients do really well with this, actually, surprisingly, but it hasn't really gained as much traction, I think primarily for two reasons. These patients usually have kind of early arthritis. You tell them you're going to cut their thumb, they're not interested in that, right? So while people do really well with this, they're just not interested in entertaining this as an option. Something that's now kind of picking up steam over the last 10 years is arthroscopy. So you see this commonly in the knee. We call it cleaning out the knee. But basically sticking a camera into that small joint and a shaver and cleaning out the inflammation, the inflamed tissue. And patients in the early stage, so stage 1 or 2, actually do pretty well. 3 and 4 don't do as well, right? Because they're, this is stage 3 here. You can kind of see out of this, yeah. So this kind of bare area, this is bone and bone, right? The white area is the cartilage, but this is where you have no cartilage at all. So, cleaning this up is not really going to do much. That bone on bone is there, and so that's why early arthritis do well, but late stage don't necessarily do well with arthroscopy. This is even newer, so denervation. This is kind of, it actually was sort of discussed probably 10, 15 years ago, but never really gained traction until maybe the last 3, 4 years. So, pain is basically our nerves picking up the sensation of pain, right? And then, our brains perceive that, right? So the concept is, well, what if you just cut those nerves? These are just sensory nerves to the joint. And so recently, I've actually done probably 5 or 6 now. The concept, you go in and just cut the nerves that are going to the joint. It's pretty difficult to get every single nerve, as the picture shows on the left there, the number of nerves that are going to that joint. But patients typically will come back and their pain is dramatically improved. It's not uncommon that they still have a little bit of soreness kind of in the deep, meaty part of their thumb. It's hard to get down into that area, but certainly their pain is significantly diminished. The thing about this, though, is that you can't have a patient who has an unstable joint, because that's going to go on to failure. And the second thing is, if they have late stage arthritis and you do this, while it may help their pain, they may still start to progress to that Z-type deformity and lose the ability to hold on to things. So you kind of have to try and use a measured approach with when you choose the patient for this type of procedure. But they do pretty well. So late stage arthritis, what we do is what we call a trapeziectomy, and that's just a fancy term for excising the trapezium, right? So the idea here is, here's stage 3 arthritis, right? So you got the trapezium and you have the thumb metacarpal. All you have to do is, if you just remove one part of the joint, then the other part of the bone isn't just rubbing there, and that actually takes away that inflammation and pain. So in the early days, they would just remove the trapezium, and then they would just pin the thumb to the index finger metacarpal, and then you would be casted for 6 weeks. And patients actually did pretty well. And there are even still some surgeons across the country that still do this. Patients, A, don't like being casted, but B, can get some irritation from those pins sticking out. The pins will come out at 6 to 8 weeks, but there tends to be a lot of irritation. But what happened over time was you were seeing some patients come back with still some residual pain, or pain getting worse. And you would get an x-ray and you'd see that their thumb had collapsed. So, the trapezium used to be in this space here, and then the thumb used to be up higher, and then it's collapsed, and now it's bumping into the scaphoid here. If I go back here, you can kind of see, right? So here's where there's a gap, but then if it collapses into it, then it starts to rub. And the thought was that, well, that collapse has led to that pain. And so newer techniques started coming out kind of in the early 80s of what we can do to try and hold that thumb up, but then stuffing something into that space, kind of what you may have heard of, like the anchovy technique, right? So in this technique, this is probably by far the most common technique now, where, again, you're removing the trapezium, so you're taking the bone out. Instead of just pinning this, I know it shows pins here because initially they did pins, but now we don't really do pins anymore. But instead of having to pin it, you take one of your tendons from your wrist, or actually your forearm. It's connected down here at the base of your second metacarpal. So you take half of it, drill a tunnel through your thumb metacarpal, and then wrap it around kind of like a sling, and then stuff the rest of that tendon into that space to kind of serve as a cushion to prevent the thumb collapsing into that space. Interestingly, well, so patients here still will get casted for 6 weeks, and then they come out and they start therapy, and they do really well. And it's still by far across all hand surgeons, probably the single most technique that's used. But what we found is that patients still have collapse even with stuffing a bunch of graft into that space. Now, some of those patients have pain, some don't, so it's not really sure as to whether that collapse is the source of that pain, but still, you're still seeing some collapse. So the momentum is starting to swing to, well, do we really need to go to the forearm and harvest a tendon and then, wrap it around and drill these tunnels? So there are simpler techniques that are now coming out. This is what we call a suture suspension plasty, where you just take the trapezium out, but instead of trying to grab tendon from somewhere else, you're just using suture, and you're tying suture back and forth between two of your tendons underneath your thumb and creating a hammock there. Very quick, very easy. Patients are only immobilized for like 2 weeks, so you're not casted. You get them into therapy sooner. Do pretty well. I used to do this early on. I initially started with that LRTI procedure, which I showed before. Then started doing this when it didn't make as much sense to go harvesting a tendon every time. Patients did pretty well. Again, you can get them soon. You can get them out sooner, start therapy. But I started to see some pullout, meaning the suture would pull through the tendon. It wasn't very. I didn't feel like there was as strong of an anchor point there. So then a newer technique came out, which I haven't. I mean, I've done them before, but I don't do it as often. This is what we call a mini tightrope. So play this video here. So it's still using suture. So again, you're taking the trapezium out. They're showing you making an incision here. There's 2 incisions, one on the side of the thumb and one kind of on the top of the hand. So you remove the trapezium, and instead of just putting suture between tendons, you drill a tunnel between the 2 bones, and then you pass the suture through that tunnel. And this suture is actually really, really tight, very strong suture. This concept was initially used in the ankle for like high performing athletes who get like a high ankle sprain. They do a syndesmotic fixation. This is the same technology. And then you put these little metal caps on the end. They call them suture buttons on the end to help hold it there. And it's a pretty rigid construct. Again, you can get patients moving up pretty quickly after this. After like a week or 2, you can get them moving. Does pretty well. The issue with this is if not done well enough, you can get irritation. Those are metal buttons, so they can sometimes cause irritation over the nerves here and on the top of the hand, and they can sometimes be, if you don't drill your tunnels correctly, that can be an issue. You can also get fracturing of the second metacarpal through that second tunnel, so that's another kind of complication that could occur, but still patients do pretty well with that. This is an x-ray showing kind of the metal buttons that you can see when done. There have been a number of prosthetic implants. So for instance, like in the knee and hip, you hear people get knee replacements, hip replacements. And in the early days, physicians would try and come and invent different types of joint replacements for these. And invariably, they all failed, right? They all loosened. And it's primarily because of how much force we put on our thumb. And these implants weren't well constrained. And so you'd get dislocations like pictured up here in the top right. This is just a spacer, it's a pyrocarbon spacer that would spit out. This you can see is loosened, so the alignment of the whole joint shifted. So invariably, these all failed, the early generations. But there are newer generations coming out, but we don't have long-term data. So this is just a different kind of pyrocarbon spacer. These are what we call hemiarthroplasty. So you're only replacing one side of the joint. So here they cut half of the trapezium, they kept the thumb metacarpal, and they just stuffed the spacer in here. This is the opposite. They cut the bottom half of the thumb metacarpal to keep the trapezium, and they put this metal implant in. Early data is good, but we don't have long-term data. And I think what remains to be seen is what happens kind of 10, 15 years down the road. In my opinion, what if this fails? Like, you kind of, not that you're screwed, but it makes it very challenging to deal with at that point. So that's why I don't tend to entertain that at this point. So, and then the young patient. So someone who's a laborer who's maybe had an injury or just developed arthritis from use and activity. In those patients, we'll do a fusion. So Fusions where you're basically making two bones, now one bone. So you're cutting the joint out, you're putting both bones together, and you're putting a plate on there for them to, over 6 weeks or so, to fuse as one bone. It's just showing the x-ray there where the trapezium and the thumb metacarpal are now one. Does very well in the young population. However, over time, as you know, patients, for instance, when you have a fusion in your neck, right, you get a C5, C6 fusion, 15 years down the road, I can guarantee you at C3 and C7, you're gonna, or yeah, C5, 6, yeah, so C4 and C7, you're gonna get arthritis at the level above and the level below. And invariably, you will get arthritis at the MCP joint and down the STT joint, just because there's so much force that used to be going across here, now has to go across the joint above and below. And so those tend to wear out a lot quicker. But it's definitely more robust for the manual labor in terms of force. So that's why we typically entertain it. So my technique, it's sort of a hybrid, right? So I like the aspect of using the suture in the sense that, you know, there's no reason to have to go to the forearm and grab tendon, in my opinion. I still use some tendon, but I don't go all the way to the forearm and grab it. But I also incorporate the LRTI, which is basically where you do grab tendon in the wrist. So taking the trapezium out, I drill a tunnel into the base of the second metacarpal, but the suture implant here doesn't have a metal button on it. So you don't have that irritation on the top of the hand. It's an all suture knot technique. This is just showing drilling the tunnel. And then you deploy this suture anchor here. That again is an all suture button technique. So it's just a soft suture on the top side of the hand, but you rarely feel it. So there's very less irritation. The tunnel's a lot smaller, so you don't have the risk of fracture. And then you drill another tunnel at the base of the thumb. Again, this is all internal. So you'll see here once this tunnel's drilled, the suture is then buried into the base of the bone. So there's nothing sticking out that you can have irritation. But then I supplement it by taking, so that's what it looks like on the left. I supplement, I don't have a good picture of this, but instead of taking the tendon from the forearm, in that same incision at the wrist, I'll take half of this tendon about to here, just swing it around and attach it to the base of the thumb. So now you have a synthetic suture graft that's holding it, and then you have a biologic graft, your own tendon, that's kind of a cross cruciate that helps to kind of hold the thumb up. You can get patients moving early. I don't cast. I just splint for 2 weeks, and then they start therapy. They get a removable splint and get going. So it has the advantages of not having to cast for 6 weeks. Done it for now almost 2 years, and pretty reliably have seen good results. So that's what I do. So I'll say this about all these techniques. There's not one right or wrong answer, right? They've done studies that compared all of these things. The one aspect of all these procedures that's the same as you're taking the trapezium out, right? Everything else is, you can invariably see the same results in terms of success rates, strength, grip strength, patient satisfaction, decrease in pain. So I'm not going to sit here and say mine's the best. It's just anecdotally, I think that there's less irritation and I can get patients moving quicker, which are kind of two important things in my opinion. But when is the right time, right? So I never tell patients like you need to have surgery unless they're coming back and they're in a lot of pain, right? They got to tell me they want to have surgery, right? So if they've tried everything, they've tried injections and they're back 2-3 months later and they're just like, man, pain's really limiting my ability to do what I want to do. And that's when it's time to talk about surgery. But what you don't want to do is wait till you get to this, what we call Z-type deformity, because that makes it more complicated, right? The surgery is more involved, your outcomes aren't as favorable. But oftentimes what you're having to do is now fuse the MCP joint to make it a more stable, useful thumb. If only we address this side, you're never going to have that power to hold on to things with that thumb. So it's, while I say, you can try and wait things out, I certainly wouldn't wait till you start to get to this type of deformity. So we'll talk about some of the post-op rehab.
So as Dr. Netto went over, there are so many different versions of this surgery. So depending on the surgeon that you go to, there is going to be a lot of variability in your rehab following surgery. There's also some other things that can cause that protocol to vary. So some things such as age, as we get older, our bodies heal at a slower rate than when we were younger. So that may change how you progress through the protocols. Stability of the joint, if we're not seeing the stability that we would like to at certain intervals in your recovery, it may cause you to, we may have to take a step back, wear splints longer. Underlying medical conditions can also cause variability. And then if there was any complications in surgery, that can also cause variability. So on the next slide, I'm just going to be talking about a general guideline of what rehab would look like following Dr. Netto's surgery. So as Dr. Netto touched on, weeks 1 and 2, you are wearing your post-operative splint. You're wearing this at all times, but during this time, it is so important to make sure that you are continuing movement of anything that's not involved in that splint. So you want to be making sure that you're moving your other fingers. You want to make sure you're moving your elbow, your shoulder. Doing this will help you to make sure that you are decreasing stiffness in those joints and decreasing swelling and edema as well, because you're getting movement through that extremity. So at week 3, this is when you get to start hand therapy. So at this time, that post-operative splint will be removed and you will be fitted with a custom orthosis. So I'm going to send those around as well. These are some options of what that could look like. If you try these on right now, they obviously won't fit you because they are custom molded to patients' hands. So if you want to look at those. So at this time, when you start hand therapy, your exercises are going to be what we call active range of motion. So this means that you are using your own muscles in your hand to create the movements of your thumb. You won't be applying any external forces or stretching of your thumb at this time. So then we continue those exercises and you are continuing to wear that splint whenever you are not doing your exercises until about week 6. This is when you continue with those active range of motion exercises, but then we start to initiate at this time passive range of motion, which is then where we are able to use that external force to make sure we are progressing your mobility back to functional limits. At this time, we will also initiate strengthening. We will start with what you are able to tolerate and slowly progress that at the discretion of your therapist. And at this time, the splint is discontinued for day-to-day activities, but you will still want to be wearing that splint when you're doing any strenuous tasks. I know week 6 to month 3 is kind of a big jump, but this is really where you get to start having a lot of fun in therapy, progressing that strengthening, really getting more specific towards what your day-to-day goals are and what the things you do day-to-day look like. But then at month 3, if all is going as planned, that is typically when the splint is discontinued fully, and that's when you're able to return to full activity. Do you have anything that you want to elaborate?
Yeah, I always tell people before we end up signing them up for surgery is, this is more of an investment on your time, right? So surgery takes an hour and 15 minutes, but it's really the investment is on the back end, the therapy, the rehab. Right? That's where you're going to see your outcome. And anyone that tries to sort of, cut the corner on that, you're really just asking for pain that just gets prolonged, right? So we got to try and still protect things, but still get some of that stiffness and motion out. So I tell patients at 3 months, while I have no restrictions, you're probably still only at 60 to 75%. Limitations being, you're still going to feel a little stiffness, you're still going to have a little soreness, but pretty reliably by that 6-month mark, you're pretty close to 100%, right? Sometimes you tell them like 6 months, like that, it goes by a lot quicker than you think, but it does take, like we're physically removing a bone out of your wrist, right? It's going to take some time for your body to sort of figure out what its new normal is. So that's something to keep in mind. Questions?
I have
Yeah.
a question. So with the physical therapy, how often would you go in for your physical therapy sessions?
Yeah, so that will typically,
Can you repeat? Yeah.
oh, yeah, sorry. So she was asking after surgery, how often are you coming in for rehab? So at the beginning stages, we may just do like weekly check-ins to make sure you're doing that active range of motion, you have your home exercise program. And it's really when we get into that passive range of motion phase at about week 6 that we want to start seeing you more consistently, about 2 to 3 times a week.
Are you referring to after surgery or before? Okay.
After surgery.
A lot of the braces for your thumb come down over your wrist, and I'm wondering I'm assuming that you, what is the harm of immobilizing the wrist a lot? When-
Yeah, so the question is, some of these braces that you can buy over the counter do cross the wrist, right? Now, I'll be honest, you did pass it around, I saw earlier, but
Yeah.
the brace I typically use is the Comfort Cool. Reason I like that one, that one does cross the wrist, but it is more, it's neoprene, so there is a little bit more flexibility in it. Yeah, this one's huge, but I think I use this one
Oh.
here. Yeah, this one's actually, I've never
A
seen
forearm
that.
brace.
Yeah, that's forearm. So this one still crosses the wrist, but I've found in the past there are other versions that just come to the base of the thumb, and to me, and they're usually kind of hard. It's like the Modab or I sometimes like some patients love them, and that's great. It's fine if it works, but I find that sometimes that can kind of dig in to the base of the thumb, right? And that can create a source of irritation. So I don't like it as much, but if it works for you, great. Now, some patients will come after going to like, some drugstore and buying an off-the-shelf one, which those have these metal stays in them that really make it rigid. It almost makes you almost not be able to use your thumb. And granted, that helps with pain, but it does foster stiffness. So if it's crossing the wrist and it's pretty rigid, I don't necessarily like that because then your wrist gets stiff. These at least are soft, so you're still able to move. I mean, it does restrict some of the thumb motion, but at least it does allow you to move your wrist more. I find that's more beneficial, but I wouldn't want to immobilize the wrist in something very rigid if that's something you're gonna be wearing consistently.
And then were you also kind of wondering about the post-operative splint, why we're immobilizing the wrist?
No. I
Okay,
think it's more
more
the-
the- okay,
Yeah.
that's-
Yeah, that's different.
Yeah.
We want to immobilize the wrist there for a little bit.
So another question I jotted down was, so after physical therapy or the surgery, if it's extreme, does your functionality go back to normal?
The short answer is yes. Well, I will say after surgery. So, physical therapy early on, you're talking about after surgery or just even before?
After surgery?
Okay. Yeah. So the short answer is yes, right? So, the studies bore out show that grip strength improves significantly, pain scores go down. I would say that if you were to try and compare it to the non, or not, I would say the non-dominant hand, I would say the contralateral hand, right? There may be some diminished pinch and grip strength if you were to objectively measure it with like a dynamometer, but most patients don't realize that because prior to it they had very little strength because of the pain. So typically they feel phenomenal afterwards, but it does take a good amount of time to get there.
Can you talk a little bit more about the PRP and stem cells? Now that I watch daytime TV, I see thousands of commercials.
Sure.
kinds of stuff.
So the question was talking more about stem cells and PRP, right? So I'll be honest, like I don't deal with PRP or stem cells. In our practice, there's one provider that does do some of them, but the concept there, at least with the PRP, is that you're taking your own factors that are commonly secreted by your body in the setting of an injury, and you're harvesting that and then injecting it into the site. The thought is, okay, those factors can reduce inflammation, which will then reduce pain. Or if it's something like an injury, you're injecting into that area that can help to sort of stimulate your body healing. By no means is it going to regenerate the cartilage, right? Once the cartilage is worn away, it's gone. There's nothing that's been able to demonstrate the fountain of youth of regenerating cartilage. So in my mind, you can try and inject this stuff, and it's coming from your own body. It's the stem cells. I'll be honest, I'm not as well versed because I think there are some that are, I don't think they're coming from you. I think they're coming from elsewhere. But even then, nothing's been able to demonstrate the regeneration of cartilage. So in arthritis, to me, it makes really no sense to go that route, especially when it's cash pay. But if you have the means and you want to try it, well, I don't think there's any downside to it. I just don't think that you're going to get much relief long-term out of it.
They talk about some kind of gel, especially with your knees and those things.
Yeah, so that was the hyaluronic acid injections that I was referring to, right? So your joints secrete hyaluronic acid is what helps lubricate your joints. So this is basically a formulation of that and injecting it, right? Even that, I mean, the studies show that there is some benefit to that, but it's not yet been FDA approved in the wrist and hand. So the ones that are approved are for the knee. So you get 6 cc's of that injected typically once a week for the next 3 weeks, right? You can't fit 6 cc's into your thumb. I mean, you'd explode. You can maybe fit 1 cc into there, right? So it hasn't been approved. I think you could probably buy it from a compounding pharmacy if you wanted to buy it yourself, and then we could certainly inject it by all means. That's not a problem, but it becomes very expensive. It becomes very expensive that route. Yeah.
Just a quick question. Hopefully it's gonna be down the road. I won't even need it. Thank you to Elli and for getting my thumbs up. But anyway, the denervation part of things, highlight a bit more that as far as conditions that you think that would be the best route.
Yeah, so currently I'm just doing it on patients who come in with pretty significant pain, but you see their x-ray and you see very early arthritis at best. But yet they're having a lot of discomfort and pain that's limiting their ability to use their hands. Their joint is stable, so I don't feel any laxity there. And the procedure is pretty straightforward. I mean, you're going in there and you're cutting these nerves, and it's nice because 2 weeks later, once the incisions heal, you let them go and they're doing great. But if I'm starting to see pretty significant arthritis or I'm getting some deformity, I don't think it's a great option long term. Unless for whatever reason they're not a great surgical candidate to go through all the rehab on the back end, but they're in a lot of pain, so you're just using it as a sort of palliative method. And maybe in that case, I haven't used it in those patients yet, but certainly on the younger side or the early arthritic sides, I've used it so far. It's good results.
When we talk about physical therapy, no surgery involved, just
Yeah.
physical therapy. Is there a difference, like if you have bone on bone already, is there a point to physical therapy, or do you save that for where there's not such a bad, there's
Yeah.
still some cartilage?
Yeah, absolutely. I mean, you can probably,
The question was
Oh,
the
thank you.
use of the role of physical therapy before surgery and how much benefit you could potentially get from that. I still think there's a role, right? It really depends on what your goals are with your treatment plan. So if you're like against the idea of surgery, which is not a bad option necessarily, then certainly there's a role for therapy to try and modify some of the tasks you do commonly throughout the day, whether it's holding a simple pencil or things of that nature. They can teach you things to go that route. I would say that no question, therapy has been shown to be very beneficial in the early stages of arthritis. So stage 1 or 2, you're going to see some good improvement with working on, strengthening some of the muscles around the thumb. As you get to 3 and 4 stages, I think the benefits of therapy become less, but they can certainly teach you different ways in which to get through your normal activities of daily living to make it more manageable.
any questions from Zoom?
I have one more.
Yeah.
sorry.
Yeah, sure.
That's
no
okay.
worries.
Don't apologize.
So I know, so when I hold my cup of tea, it feels so good on my thumb, but I know they're inflamed. And so when I Google, it says, oh, you can use heat or you can use cold. Well, they both feel good, but when I'm holding it on my cup of tea, does that damage it worse to add to that inflammation there? No.
I tell patients do what feels better,
Mhm.
right? Ice can certainly reduce inflammation. Heat tends to promote blood flow to the area, right? So there's kind of potential benefits with both routes. And you can speak to this, but normally in therapy, they'll start with heat at the beginning of your session and then end with ice at the end if they've been kind of working on things, right? So they're still doing both modalities. But I'll tell patients to try both, like whatever works best for you.
And sometimes that heat too can help to soothe some of those tense muscles in your hand as well. So there's some benefit in that as well.
Cool.
Awesome. Well,
Well-
thank you guys so much for coming in, participating in this presentation, all of the questions, we appreciate it. And afterwards, feel free to come and talk to either one of us. There's also a lot of other hand therapists in the room for Spooner if you guys want to raise your hand so people know that you're also hand therapists.
Great, yeah.
So feel free to talk to any of us as well. But thank you guys for, thank you. Feel free to grab food, drinks, cookies on the way out. And there's also some materials in the back, some of those products that I talked about in those exercises. Thank you so much.